Thank you. So you're probably used to me talking and hearing lectures about intense pulse light for dry eye, pulsing light energy to help a medical condition. This is a little bit different. This is pulsed energy, but pulsed laser to help a medical condition, which is glaucoma. I told him I would introduce myself because I think this is kind of important to tell you why I'm involved in glaucoma. Essentially, Memphis, which is one of the few cities in America that's the population is over 50% African American, has a serious glaucoma problem. And we used to have some great glaucoma surgeons in Memphis. We had Dr. Sarkeesian, we had Dr. Netlin, and those guys went away. And it left a big vacuum in Memphis on who was going to treat glaucoma. So a lot of these patients actually started coming to our clinic. So it kind of forced me to be a little bit of a glaucoma specialist and forced my wife, who's also an ophthalmologist, to be a glaucoma specialist. So we're constantly looking for new technologies to bring to our clinic to make things better. And then when I heard about this pulsed laser technology, it's right up my alley in terms of the technology that I like to use in our practice, because I'm a big believer in pulse technology, and I'm a big believer in light and specific wavelengths to kind of help medical conditions. So I think if you're here at this meeting and you're here sitting down, you know that glaucoma is a very serious condition that is not being treated aggressively enough, and that we have patients that are losing their vision, and it could be one of the #1 reasons why people lose their vision in the world. So I've been in Memphis for 18 years treating glaucoma patients. There's fewer glaucoma specialists in the area, so now it's being taken up by more general ophthalmologists and other specialists. I was talking to a glaucoma specialist last night. It was actually Dr. Netlin, who runs a program, and he was telling me it's harder and harder to fill residencies with glaucoma fellows. So there's going to be a big shortage out there, and I think more of the ophthalmologists that are out there are going to have to start taking on this battle. What I've learned in these 18 years, especially in that African American population, if you do not treat them aggressively, they will lose their vision. So I think we've been a little bit complacent in how aggressive to treat these patients. Patients aren't using these multiple drops. Compliance is down, and that could be a financial thing. In Memphis, it seems more financial than it is behavioral. These patients come in, and I say, "Are you using your drops?" And they say, "Well, I ran out, and I didn't have the money to pay for this drop." So we're more and more looking for ways to do this with out drops. I feel like we've been losing the war on vision. I can't tell you, we just bought a practice of a retiring physician, no knock on him, but he was treating less and less aggressively on these patients. So we're getting patients who have a 0.8 cup to disc, 0.9 cup to disc with a 3+ to 4+ cataract, and they're 82 years old. So one of the things is, if you look at the census on how long we're going to live in the future, if you're a male right now, you're going to live over the age of 40, you're going to live to the age of 82, and if you're a female, you're going to live to the age of 86. So if we have these glaucoma patients of 45, 50 who have a 0.7 cup to disc, what is going to be the financial burden on the system when these patients completely lose their vision at 55, 60, and then they live for another 25 years? So our practice, because of this compliance issue, we adopted MLT, which decreased the number of drops. It helped our compliance issue. And how we talk to patients about this is, when a patient's sitting down with me, I say, "Ma'am, you have this problem with glaucoma. There's a couple of ways that we can treat this. We have drops that can treat your glaucoma to lower the pressure. We actually have this soft laser, an MLT laser that can treat it. If the MLT laser and the drops aren't working, then we have a stronger laser," and that's the crux of my talk, is how we're incorporating the stronger laser, the Cyclo G6, in our practice. And then the final thing I talk to them is that there's surgical options. If you look at reports right now, the #1 fear of patients when they have eye surgery is, just think in your mind, is blindness. So when patients, when you tell them they're going to have actually eye surgery, the first thing that comes into their mind is that they could go blind. So if you have an option that is less invasive and sounds less invasive to the patient, they'll be more apt to say, yes, I want to do this procedure. If you tell them we're going to do surgery, they're thinking blindness. So doing these things, surgical procedures make sense. This is a Canadian study showing that if you do a stent, that you're going to save money in the long run as opposed to using drops. So it makes sense that we're getting more surgical. What's very interesting is, as we're finding out this information, the government reimbursement for surgical procedures are going down. So my surgery center was telling me that they weren't sure if they were going to continue to do eye stents because they're not getting reimbursed as much from these insurance companies. So we're going to have to find another thing to do. And this is going around all over. And this might be the reason why you're seeing fewer and fewer surgeries, because if the surgery center's not being reimbursed properly and the doctor's not being reimbursed properly, you're going to see less of these surgeries. So we do have an alternative to surgical options, and what you're used to is cyclodestruction of the ciliary body. Now, and that's of course one option when these patients have uncontrolled glaucoma, but a better option is pulsing that energy so that instead of destruction of the ciliary body, you actually just get decrease in the function of the ciliary body, and that's where the Cyclo G6 comes in. So it's a new treatment for glaucoma, micropulsing that energy. So like I talk about when I talk about intense pulse light, instead of just giving a flash of energy, what you're doing is you're pulsing and chopping up that energy into small bits. And what that does is it gives the tissue that you're treating some cooling relaxation time. And as the heat is transferred to that anatomy, you actually give it a little time to respond, and then you hit it with another pulse of energy. So you have two probes that you can use. You're used to the more cyclodestructive probe, but here with the pulse probe, the main thing to see is that the G probe is for cyclodestruction of the ciliary body. The MP3 probe is not destructive to the ciliary body. So you can actually do these treatments multiple times. So we've had patients that didn't respond to our first treatment the way we wanted them to in terms of lowering their pressure, and then we gave them another treatment. And you're going to see some data from our clinic. So here's myself doing a treatment. So again, this goes to the psychology of it. Instead of taking a patient to the OR, this is being done in my office in an exam room. So right there, that whole fear, and I don't have patients giving me that fearful look when I say surgery, because I just say, look, you had the gentle laser we tried, now we're just going to a stronger laser to treat your glaucoma. These are the energy levels that we're using right now. We do actually a 2-pass system. That's evolving as this technology evolves and as our comfort level with the technology. So we actually do 360 degrees of treatment, 80 seconds, and with those parameters twice. If the patient doesn't respond after 2 treatments, we bring them back and then we do it 3 times if we want more of a response, if we need to. So this is this whole, instead of giving energy all in one shot, we're doing pulses of energy, we're allowing some relaxation, thermal relaxation time, so that we're not destroying the ciliary body. So we're not just destroying the cells, we're actually disrupting the cells so that they work less effectively, so that we get less aqueous. Now, what I've learned in any of these laser technologies and light technologies is there may be other mechanisms of action at work. Right now, there's a lot of study going on with infrared and AMD in terms of giving infrared to AMD patients to make their RPE cells work better. So it could be that maybe this wavelength of light is actually doing something to the ciliary body that's making the ciliary body work more effectively. And I think we're going to find that out more and more. There's more laser and light technologies that are being used in everyday medical conditions. These patients do need a modified retrobulbar. You can call it a modified parabulbar, you can call it a modified retrobulbar, but they do need anesthesia because they're going to feel this light energy. So what we do is we actually give them this modified retrobulbar, we give them the treatment, we patch them, they go home, they're patched for 4 hours. After 4 hours, they go home. After the 4 hours, they take the patch off, and then they do Durezol every hour until they go to sleep. And then they come back in post-op, we look at the anterior chamber, and then we start to taper the Durezol. What we found is that these patients need to have the Durezol for at least 3 weeks. So we start them strong with Durezol, and then we taper. And you're going to see in my results the effects of using a steroid. And then if they want a Valium or something, we'll give them a Valium. The patient that I was showing you there, he decided to self-medicate himself with some drinks before he came in. And when he went home, he said it was great, I fell asleep. So we have a lot of interesting patients in Memphis. So look, there's all sorts of techniques that you have, and this is evolving for us. We actually do 360. When the reps came in, they told us to go on a pattern of not 150, 140. They also said, you can do 80 seconds on one side. So like my wife, when she does a treatment, she does 80 seconds on one half of the globe, and then she does 80 seconds on the other. I actually go 360 degrees in 80 seconds, and then I do a second pass, 360 degrees. And again, you might come here next year, and I'm giving this lecture, and we might have a different protocol and different parameters because we're learning this thing as we go and how we can use it. So the advantage is it's non-incisional. You're not saying the word surgery to these patients, you're saying laser. There's minimal to no inflammation post-op, but we're actually controlling post-op inflammation by giving these patients steroid. If you didn't give them the steroid, they would have inflammation. It's low downtime. I mean, they're coming in the next day, we're seeing them post-op just to see how they're doing, and then they come in maybe every week or so. Since we're doing studies right now, we're trying to figure out what are the parameters and protocols, so we're having these patients come in more frequently. It's repeatable, so this isn't a cyclodestructive procedure, so these patients can have multiple Cyclo G3 procedures. And just because they didn't show a response with the first treatment doesn't mean that if you actually give them more energy and a different treatment that they aren't going to respond. So we had plenty of patients that we've given them 2 cycles of 80 seconds. They didn't respond as much as we wanted them to, and we actually went ahead and gave them 3 cycles, and then that did the trick. And again, we're going to start to work with the energy levels and the pulses and the pulse durations to see if that actually makes a difference and could make this more effective. So this is a study. It was a 6.5-year look back, and this is actually these studies. I read this one and 2 others, and so did my wife, and we decided, okay, we're going to go ahead and make this investment in this technology because it showed that you're getting dramatic decreases in pressure with this micropulse as opposed to a cyclodestructive procedure with little downtime. So, and it's consistent. So here you see with a 6-year follow-up that these patients actually have pressure that stays low. All right, so what we did, we had 20 patients, 26 eyes. We lost a couple to follow-up. They had anywhere from mild to severe glaucoma. This is the needle that we've decided to use, a 25 gauge hypodermic needle for our modified parabulbar, modified retro. We go ahead and do that in the office, right there in the exam room where we have the Cyclo G6. You can see after the procedure, this is the patient that self-medicated himself, but after the procedure he's comfortable. He has a little redness, and you're going to see a little conjunctival redness. Don't let that scare you. It goes away. Little subconch heme, not a problem. And then our techs patch him, and we give him specific instructions to just go home, but in 4 hours after that, go ahead and start your Durezol every hour while you're awake, and then you go ahead and patch that night. So this is the distribution of patients. We had mild, moderate, and most of these patients were severe, because this is like the first round of patients that we were doing, but now we're actually doing more and more moderates with the Cyclo G6. And we had a decrease in pressure immediately after post-op day 1 in general with these patients. If you see this little spike here on day 14 on that baseline, we actually have our patients on Durezol for 3 weeks. So a lot of these patients are high risk steroid responders. So what we're thinking is that little bump that we see there is having those patients on the Durezol for 2 weeks. But we find that controls inflammation, and then we don't have to worry about inflammatory glaucoma. And then once we get them off of the steroid, then we see again that drop in pressure that consistently stays. And then, you know, the main thing, and this is a huge thing, again, in my practice, is if we can lower the amount of drops that these patients will take, we're going to increase the compliance. So we go from 3 drops to mainly most of these patients have gone down to just 1 drop. So 73% success rate of getting patients below an IOP of 21. We get IOP reduction of 30%, and what we see is actually the higher the pressure, the more dramatic of a pressure lowering effect we get. So if they come in with, like that other study, if they come in with a 46 or 50, that's where you get the 50 to 60% reduction. Average 1.1 treatment. So there was a couple of those patients that we did bring back and we gave them more treatment, and 2 eyes did go on to get TRAB, but if you look at the severe that we had, that was going to be 18 patients that were actually going to go and be scheduled for TRABs, but we actually did the Cyclo G6 instead. So in my book, out of 18 patients, we saved 16 from having incisional surgery. And that's not to say that they would even have signed up for the incisional surgery. So we get 30 to 45% IOP reduction, 50 to 60% medication reduction, more effective than a medical therapy, as effective as for us as a TRAB or a stent with fewer complications. It's an in-office procedure, and if here in the United States, and I know we have some foreign doctors here, but here in the United States is the government for Medicare is trying to push more and more for in-office procedures. They want us to do in-office cataract surgery. They want us to do in-office glaucoma surgery. So you're going to be hearing this more and more. My representative in Tennessee is Lamar Alexander. He sits on the head chairman of the health committee. I would listen to his podcasts because they're very relevant, and that's what they're talking about, how to decrease the cost curve in the expenses in healthcare. And how they're going to do that is bringing things in office, taking them out of the hospital, taking them out of the surgery center. So if you think that the days of you doing any surgery that you want and it being covered, those days are slowly going away because they don't have the money. It's a safe procedure. We haven't had any hypotony with micropulse. The number one thing that you see is inflammation, but I think we've controlled that with putting these patients on Durezol. It's predictable, non-invasive, and you can add any type of drop that you want afterwards. So that's my talk. I'll take any questions.
When you're actually treating, are you just sweeping along the limbus
area?
Yeah,
so we're sweeping around.
Hear the questions better.
Oh, okay, I can hear them. So yeah, so what we're doing is we're treating around the limbus. That's 3 millimeters. That light energy is 3 millimeters away from where we're treating, putting that probe on the limbus. So it's getting to the ciliary body. So there's a little notch that tells you how to turn that probe and where to put it. So that you don't mistakenly turn the probe the wrong way. So that's one thing that I would just look at right away, that you're doing it that way. And again, we're learning how we started using this. We had a back and forth sweeping motion, but now we've gone to trying to go 360 in that 80 seconds. That's the way I do it. My wife does 80 seconds where she goes 180 and goes in those 80 seconds, and then her second 80 seconds is 180 inferiorly. So, you know, we're going to find all sorts of ways on how to do this and what's the best parameters.
Are you actually pushing the foot pedal each time you're setting the pulse, or is it you're holding down a foot pedal and moving it?
You just hold down the foot pedal, and then you'll hear it. You couldn't hear it here, but it's an
Hear a
audible
click?
sound that's telling you the seconds ticking off. So it's beep, 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 and then it'll stop at 80. So you just hold it
Understood.
down and you just go.
Thank you.
Question regarding visual acuity. What is the visual acuity you get post-operatively in these patients? Any case of cystoid macular edema or any other complications? Such
So
as
we
that?
haven't seen, okay, and that's a great question. So he's asking if we're getting any decrease in vision, and before we controlled the inflammation, we were getting that. We didn't get anybody with clinically significant macular edema that we saw in OCT, but the inflammation was pretty intense. So there is an inflammatory component to giving these patients this micropulse energy. But I think we solved that by giving them the steroid. You might get a little bit of a bump of the pressure at 2 weeks, but it goes away once you stop the steroid.
Do you have exclusion?
Yeah, I'll take that.
Is it on? Hello, can you hear me?
Yeah.
Okay, do you have any exclusion list, or for example, would you do it on a patient with uveitis or rubiotic glaucoma?
We're not doing that currently, and a patient with uveitis, I don't think so. There is an intense inflammation that happens with this. So when we started, we weren't giving that much Durezol, and some of these patients were coming back with actually a fibrinous reaction in the anterior chamber. So I wouldn't push that. And then the rubiosis, I wouldn't. Again, we're not at that point yet. We need to learn more about this laser. We've had it for over a year and a half. So what we've done is we've gone and we've changed the curve. So it used to be just reserved for our severe, but now it's reserved for even our moderates and our milds that we want to get off drops, and that MLT hasn't lowered their pressure enough. But we're more aggressive now with glaucoma than we were before. So.
So from a practical standpoint, do you get paid for the probe when you do it in the office, or how do you get reimbursed for that as opposed to ambulatory surgery center?
So if you do it in an ambulatory surgery center, there's a surgery center fee that is paid to the surgery center, and then there's your fee. So it's kind of like a YAG capsulotomy. If you were to do a YAG capsulotomy in a surgery center, your doctor's fee would be reduced, and the surgery center would collect a fee. If you do it in your office, then your surgeon fee is increased, but then there's no surgery center fee. But this is what I was telling you about before is the government is looking at this. They're looking at what can be brought in office and what has to stay in a surgery center. And they want to bring all of those procedures that do not, they deem not necessarily having to be done in the surgery center, they want to bring in office. My wife wrote a great article, I think it was in Ocular Surgery News, talking about in-office cataract surgery. And if you haven't seen the study out of Kaiser Permanente, they did over 30,000 patients in California in-office cataract surgery with no complication rate, a lower complication rate than was seen in a surgery center. And the federal government is using that as a way to show that these procedures can be brought in office. So this change is happening, and we're just going to, as physicians, we're going to have to adjust and get used to it. So you get more money if you do it in your office as a surgeon fee. You get less money as a surgeon if you do it at a surgery center. So the surgery center would pay for the probe, and they would pay for the equipment. So that's why they're getting a surgery center fee. But I think those days are, I guess what I'm telling you is those days are slowly going away. The days of I have my YAG in my surgery center and I'm getting a surgery center fee for my YAG capsulotomy, those days are slowly going away.
Is there a level of visual acuity above which you would not recommend doing the procedure?
No, we actually have not done that. And visual acuity when it comes to the glaucoma patient is just so relative. You have patients that are quote unquote 20/60, but they come in and they're not functionally 20/60. So our goal is to lower the pressure.
You wouldn't be afraid of doing this in a 20/20 patient?
I would not be afraid of doing this in a 20/20 patient with adequate follow-up, and that's sometimes the problem, that they have to show that they're consistently coming for their exams and that they're not a patient that we're going to lose to follow-up. In that study, we lost 2 patients to follow-up, which is not uncommon in Memphis, sadly.
Are you doing this in open-angle glaucoma and in closed mixed mechanism glaucoma? Has it been working in your narrow-angle patients?
Well, if there are angles open after we do a PI, then we'll go ahead and do it. If not, we'll do the PI first.
And have you seen any difference in the amount of inflammation if they're phakic versus pseudophakic?
Both of them. That's a good question. I'll have to go back and look. About 80% of the patients in that study were pseudophakic. About 80% of the patients in that study had a prior MLT. But I'd have to go back and think about it, whether inflammation was increased in a phakic patient versus a non-phakic.
And by MLT, do you just mean like a SLT or ALT?
Yeah, correct.
Any more questions?
Well, good. Thank you. If you have any questions, you can reach me at our clinic, and I'll call you right back. Great, thank you.